no matter, we can carry on in his absence. Welcome everyone to today's webinar. It's a part of a series of webinars we're conducting around the topic of the American Society of Hematology conference, which is I believe the biggest conference in hematology that goes on every year. This year it was held in Atlanta, Georgia, but also online. And we're aware that these conferences can be quite intimidating for patients, but they may also hold some interesting information as to the treatment and care of MPN patients. And therefore, we've asked two very distinguished speakers to come along and tell us a bit about what they thought the most interesting things are. And we'd be really interested also to have some questions from you to make sure we're answering everything that we possibly can. So just to introduce myself, in case you haven't been on a webinar with us before, I'm Charlotte. I'm the Patient Advocacy Manager at Leukaemia Care, and I'll be hosting today's webinar and putting your questions to both Mary Frances and Adam. Before I ask them to introduce myself, just to say that the easiest way for us to take questions in a format such as this is in writing in the chat box if you're on Zoom, which is the button with the little speech bubble in it. If you're watching us on Facebook, you can also just leave a comment, and I've got colleagues who are sort of passing them our way so we can make sure that everybody is involved in the conversation who wants to be. So if I may come to our speakers today, Mary Frances, would you mind just introducing yourself for me?
Hello everyone, my name is Mary Frances McMullin. I'm a haematologist in Belfast, working with a particular interest in myeloproliferative neoplasms.
Great, thank you. And Adam, please.
Hi, Adam Mead. I'm a haematologist in Oxford, where I also run a research group where we study blood cell development and how that goes wrong during the development of myeloproliferative neoplasms. Great.
Sounds really interesting. Looking forward to that. So just to say that rather than having all the presentations and followed by the questions, we thought it would be easier to break up the presentations a little bit, so the speakers may pause occasionally for questions. Do therefore ask questions that you think of immediately or as quickly as you can, although of course I will make sure we leave a little bit of time at the end for questions where you weren't quite quick enough for me to ask them in between. But hopefully that should break up the conversation, because what we're going to talk about today is quite technical in places. So I can see someone's already asked a question, which is great. Thank you. Please do keep that up. Without further ado, Mary Frances, you're ready to share your screen. Let's kick us off.
Okay, let's see if we can do this. Can you see that? Okay.
Yeah, that's perfect. Thank you.
Right. Okay. So thank you very much, everyone, for the invite, for coming today and for turning up to hear this. So our remit was to look at the ASH 2021 conference, and particularly with a focus on myeloproliferative neoplasms, and think about what highlights there were there. Now, this is actually quite a daunting task. We're all doing this online now most of the time, and I seem to have spent actually much more time than I probably would have spent if I'd been at the meeting listening to these presentations. And there was a lot of information on myeloproliferative neoplasms, but I have thought the best way to tackle this is to pick some things that I think are particularly of interest and try and look at the data that was available. So I'm always interested in treatments for patients, and that's really a big issue. So I'm going to talk quite a lot about some of the trials that have presented, some of them, not all of them. I've also, and this has already come up in the question, I thought it would be particularly of interest, was there anything in COVID and MPN? So I have one slide summarizing any of the work that was done on that. And then I'm going to end up just giving you a little flavor of some of the trials that are recruiting. Adam will follow me and will, of course, will cover different areas, but these are the ones I thought would be of interest. So the big issue in myeloproliferative neoplasms, or the unmet need, is the fact that there are people who have had treatment and become, usually with myelofibrosis, and are either resistant or refractory to the therapy. The main therapy, of course, used for myelofibrosis in the UK will be ruxolitinib, and we're talking about patients who have either lost the response to ruxolitinib or it is not effective in the first place. So many of the trials and the things that I would be interested in is what treatments can we give to these patients that may be of use. And there were a number of trials reporting, giving some very interesting results in this area. The drugs that we're looking at are usually drugs that add something more on top of the JAK inhibitors, as in ruxolitinib. And what many of these trials are doing is trying either adding a new agent or trying a new agent up front in these in this situation. And I'm always interested in how these drugs work. So whenever I look at this, the first thing I think is, what is this new drug and what does it do? And that's often quite difficult to work out what the proposed mechanism, but I will try and cover that. So the first one I'm going to talk about is what lysine-specific dimethylase-1 inhibitor, thankfully usually referred to as LSD1, an inhibitor of this drug. And this particular drug is bomedemstat. And LSD1 is the histone demethylase acquired from maturation of certain blood cells. So this is a protein that is involved in the development of cells. And bomedemstat is an inhibitor of the histone demethylase. So the first thing I'm presenting to you is a phase 2 trial of bomedemstat in advanced myelofibrosis in the group I've referred to, resistant or refractory to therapy. So this trial presented some exciting results. 89 patients were enrolled. 78% of them had reductions in spleen volume. So that's the first thing you'd be interested in. Does giving this drug decrease the size of the spleen? And yes, it did seem to. The other big issue with myeloproliferative patients, particularly when they're resistant or refractory, is that they can be anemic. And the standard drugs like ruxolitinib really do not help with this. So in this trial, 86% of the patients in the trial had a stable or improved hemoglobin. And that's really quite interesting. And one patient, in fact, became transfusion independent. The other thing you always want to know about is, what were the side effects? Is this drug tolerable? And the most common side effects were diarrhea and a thing called dysgeusia, which is an alteration in taste, but they were reasonably tolerable. So this drug, LSD1 for myelofibrosis, these are some interesting results, and this certainly looks like this will be taken forward for further development. Staying on this drug, it has actually been tried out in a different area, in essential thrombocythemia. And I think this is quite important because we certainly need more drugs for the treatment of essential thrombocythemia and polycythemia vera. And I looked hard for any drugs that were used in this situation. And it's fair to say that the vast majority of the trials are actually in the region of the relapsed refractory myelofibrosis. But here, this drug was also tested in essential thrombocythemia. So again, a phase 2 study of the LSD1 inhibitor, again, patients who were resistant or intolerant of standard care. It's quite a small trial, but it was enough to be presented as an oral abstract. So there were 34 patients enrolled. Interestingly, and very importantly, 92% of the patients had their platelet count was reduced, and 81% of the patients, the platelet count was actually below what we would consider the target for treatment, below 400. So it certainly seems to work in reducing the platelet count in people with essential thrombocythemia. Important as well, although white cell count was reduced a little, it was reasonable, but the hemoglobin, it was stable, and there were some symptom improvements as well. Same pattern of adverse events, dysgeusia, but it was well tolerated. So that looks like a potential treatment in essential thrombocythemia. And again, as you will always see in these studies, if they've a favorable result that looks like it's going to be useful, then they will be planning to go forward to a bigger phase 3 trial in this, and that was certainly planned. So that's one drug that will be taken forward in both myelofibrosis and essential thrombocythemia. Here's another one, and I'm going to tell you a little bit about the mechanism of this drug, because it actually works. It's a sort of what's called a first-in-class drug. It's the first drug working by this mechanism. So this is Graceful Surface, which is a first-in-class CD123 targeted therapy, and again has been tested in the same group of patients with relapsed refractory myelofibrosis. Now, this slide actually shows you this slide actually shows you the mechanism of action, which is quite complicated. What you have is the Graceful, which is a drug made up of a diphtheria toxin, that's the green bit, and a thing called the interleukin-3, which is a cytokine. And the drug has been made up by putting these two together. Now, the idea of this is that you can the interleukin-3 will then go to the cell surface and will attach to the interleukin-3 receptor. And that is a way of getting the whole complex to be taken up into the cell. So there it is, it goes back into the cell where it is internalized, and then it can then be split up further, and the toxin, the diphtheria toxin bit, then links on with this EF2 and inactivates it. Now, EF2 normally is involved in further development of the cell, and eventually the cells reproducing. But if you block EF2 with the toxin, then the process is switched off, and what happens is that the cells die by apoptosis. So this suggests that if you could get this drug into the cell, it would switch off a pathway, which would then end up with the cell being self-destructing, which is really what you want if you have too many cells. So that seems like a good idea. And in fact, that does appear to happen, because this is the results of the study. It's showing you all the patients right across. The orange lines are those who have both a symptom improvement and a spleen improvement. And the blue lines are those who have a symptom, just showing you the symptom improvements. And there are big total symptom improvements and both reductions in both. Below the line, less than 0 is good, because that's a reduction in spleen size or symptom improvement. So this drug looks quite promising. And again, I've put some of the conclusions from this study on the next slide. It demonstrated clinical efficacy and a predictable and manageable safety profile. And that's always what you're interested in. It doesn't matter how wonderful it is, if there are too many side effects, it's no use. Modest splenic responses were observed, so a reasonable number of people, their spleens became smaller. And don't forget, these are patients that were what we call relapsed refractory, so they've already had treatment to shrink their spleen and have lost the response to that. So that's quite good. And again, the overall survival in this trial was 26.6 months. And again, that suggests quite useful disease modifying activity for the drug, because again, these are a group of patients treated with very advanced disease. And again, a phase 3 study is planned. So the next one then I want to look at is Palabresib, which is a drug that has been used in the Manifest trial. And this is a trial that many of us, and perhaps some of you, have been involved in, again, in treating myelofibrosis. So Palabresib is what's called a BET inhibitor. And the bromodomain extra-terminal motif, or BET, is a protein that is involved in epigenetic regulation. And if you inhibit this protein, then you would expect to get changes in cytokines and also in cell differentiation. And this is what has been tested in the trial. And this is the full outline of all the arms of the trial of MANIFEST. It has 3 arms and is actually really looking at treating 3 different groups of patients. The arm 1 is second-line myelofibrosis patients who have had ruxolitinib, but either can no longer take it or it is no longer working. There were also arm 2, which was second-line, where the Palabresib is added on, and even arm 3, where these are patients who are newly requiring treatment. So there's actually quite a lot was treated of patients treated in this trial, both relapsed refractory and as first-line treatment. And some of the results from this look quite exciting. This is looking at arm 1 the hemoglobin response in patients in arm 1. And they have 2 groups, those who are not transfusion dependent and those who are transfusion dependent. And what you see at this side of the slide is in both groups, over time, the hemoglobin increases. And this is really very exciting. So you can see in both the ones who had baseline hemoglobins of greater than 10 or 100 in SI units. The problem is Americans don't do SI units, and in those who were, some of them very anemic and transfusion dependent, you can see over time on the drug, very good and significant increases in hemoglobin. So again, this would be very exciting, that a drug that treated the myelofibrosis and helped with the transfusion needs and the low hemoglobins. So there's lots more information on this trial, but the sort of summary is that it shows clinical activity, including the hemoglobin benefit. I'm showing you some slides from the oral presentation, but there were also further posters on the other arms of the trial. An overall exploratory analysis showed some bone marrow fibrosis improvement. And again, that would be quite interesting, because if underlying the fibrosis, the myelofibrosis causes a lot of the problems, if you can give a drug that actually starts to show some changes in the bone marrow fibrosis, that would really be quite encouraging. There were some, the majority of the adverse events were manageable. And then in arm 3, there was a further poster showing you some of the histological studies, really serially following up the bone marrows and looking at the changes in those. And again, some significant changes, including decreased bone marrow fibrosis and decreased megakaryocyte density. So another drug that really looks interesting in this phase. And I'm not going to show you this last trial because you've probably had enough of the trials for myelofibrosis, but it's really just to show you another trial with an example with a nice picture of selinexor, where when they followed it up across time, you can see that the fibrosis decreases. Now, there's grade 3 fibrosis, but at the beginning, week 24, there's not much change. But when you get to week 72, you can see that there's much less of this black stuff, and therefore much less fibrosis. And that's the sort of histological change or disease modifying potential that we would like to see in these trials, and that is mentioned in the MANIFEST trial as well. So those are the myelofibrosis trials and 1ET trial. I'm now going to move on to one trial that I think is very interesting in polycythemia vera. But if there are any questions at that point.
Yeah, there's been a couple specifically on the trials you've mentioned. Someone's asked a really interesting question that I was sort of thinking myself. You talked a lot about reduction in symptom burden and things like that, but you've only mentioned overall survival once, and someone's asked if there's any evidence of any of these slowing progression in MPNs or impact on actual survival.
Okay, so that's a very good question, which is not easy to answer. There are two bits to that. So slowing progression. So how would you look at that? That tends to be referred to by a phrase that some people dispute what it actually means, but it's this phrase, disease modifying behavior. So that's really what I was talking about, that if there's less fibrosis over time, less of the black lines or the reticulum, then are you then modifying the disease, certainly stopping progression and perhaps winding back a bit? Does that make sense? Yeah. So that's looked at, but in general, it usually takes quite a long time on the drug to see any of those changes. Survival is obviously what everybody's interested in, but it's not usually looked at in these trials because they are usually small and not powered to look at survival. So even in the original ruxolitinib trials, they had to do a sort of retrospective analysis where they realized that yes, there was a survival improvement, but and obviously that's what people would like to see, but you don't tend to get those results out from this stage of phase 2 trials. Because they're not powered for that. They have to look at the other measures like spleen size, like symptom improvement. In other words, are they affecting the disease at all?
So it's just too early to tell, really, for some of them. Yeah, great. Okay, I think that's answers the question nicely. The other questions are quite general, so I wondered whether we want to finish the trials and then come back to them if we may.
Okay, so we'll go on then with this next bit. Which is looking at iron metabolism in cells and then how that might help in the treatment of polycythemia vera. So I'm going to show you this cartoon to try and sort of explain a little bit about iron in cells and then how we might be able to interfere with that. So this is a cell, and what happens in the cell is iron is taken up into the cell. See, nice little flashing diagram to show that. And then it is taken through with a thing called, referred to then as FPN, and then released in the iron, Fe being iron, is released into the plasma. And that's what happens normally. But this protein hepcidin then can become available in the circulation and in cells. And when hepcidin is available, this alters basically the iron metabolism. So what you see is when hepcidin comes along, this ferroportin is blocked, and therefore these little blue circles of ferritin, which contain the iron, are not released into the plasma, but on my diagram you see gets stuck in the cells. And this is very important because then the iron is not available for making red cells, and that might be a useful issue. So if you could give a hepcidin mimetic, in other ways, a drug that acts in the same way as hepcidin, it would be interesting to see what this would do. And in fact, there is such a drug, a hepcidin mimetic, PTG300. And in this cartoon, you see a little bit of the same mechanism of how this drug might be effective in polycythemia vera. So on the left-hand side, you see the situation in polycythemia vera normally. There's low hepcidin, the ferroportin is open, and therefore there's lots of iron available to make lots and lots of red cells. And you can see the hematocrit therefore would be very high. But if you gave PTG300, this might reduce erythropoiesis because the hepcidin mimetic ends up with the ferroportin closed. There's no iron released, and therefore there's less red cells made, and in theory at least the hematocrit would be lower. And in fact, this appears to be what's happened. So there is a trial has been undertaken of this drug, which is known now as rusfertide, in patients with polycythemia vera. They actually used a very strict criteria, because they had patients who went into the trial who needed a lot of phlebotomy or venesection, at least 3 and 6 months on their current therapy. They did a complicated design, which is 4 phases here of open dose finding, titration to the right dose, then the randomization bit. But the important bit is that they had lots of patients in the trial, as you can see here, because each of these lines represents a patient going across. But what you should be most interested in is this last slide, because this is showing you on individual lines patients' rate of phlebotomy or venesection. And you can see that every single patient is needing basically no venesection by the end of the trial. So this drug is given subcutaneously once a week. And when you talk to the doctors in charge, they basically say that you can control the hematocrit with the amount of drug you can give. Now, this would obviously not be curative for polycythemia vera, but it may be a very useful way to control the hematocrit and not have to do venesection. And don't forget, with venesection, we have big variations of the hematocrit between venesections. We make people very iron deficient and they get symptoms from that. So this may well be a very different way to manage or to reduce the hematocrit in polycythemia vera. The other abstract that I haven't got here, but I've mentioned on the bottom, is there was a further trial done in this, mostly in Asian countries, where they used the same drug in patients who were not phlebotomy dependent, but just had polycythemia vera. And in other words, ones who were not needing those large numbers of phlebotomies. And even with them, with the drug, you could get the hematocrit down below the magic number of 0.45 or 45% and keep it there much more consistently than we would do currently with venesection. So this drug is again going into phase 3 trials, and I think will make a big difference to the treatment and the symptoms related to the treatment of polycythemia vera. The last trial point I want to make, and I could make lots and lots and lots of trial points, is there are lots of other drugs there which have been developed and are being looked at. And one that's particularly of interest is Prakritinib, because Prakritinib, it's another JAK inhibitor, and it seems to be useful, particularly in those with myelofibrosis with thrombocythemia. And this is a big problem because often when we're treating patients with myelofibrosis with the drugs we have available at present, we can't give the patient the drug because they can't have it if their platelet count is too low. But Prakritinib seems to be more useful in patients who are thrombocytopenic, in other words, that you can give it. So there were various analyses done of the trials that have been done in Prakritinib, and I've just brought a few points out from these trials that I think are of interest. First of all, there was symptom benefit in those with severe thrombocytopenia treated with Prakritinib. And that's important because many times we can't give treatment to patients who are severely thrombocytopenic. If we can give Prakritinib, there may be symptom benefits. The cytopenias, that's the lower blood counts with full dose Prakritinib, occurred at similar rates as with low dose ruxolitinib. So in other words, the full dose of Prakritinib is managed better than ruxolitinib. It was comparable to best available therapy in the severely thrombocytopenic. So again, useful drug, and prolonged treatment with Prakritinib was well tolerated, including those with thrombocytopenia. So those are somewhat general points, but they're sort of really back up that Prakritinib may be a drug that we will be able to use in those who are thrombocytopenic. So that's the main bit of trials. And I'm just going to switch a little bit in the last few minutes, but if there's any further questions.
Yeah, thank you. There have been a couple of questions specific on that PTG 300 drug, if we may.
So it's been called rusfertide, so that may help in the future.
Oh, I don't know. I think that's a mouthful as well. The question is if there's any data on the side effects of the drug, but also on its impact on the symptoms of PV as well.
Okay.
2 questions.
So I don't have that information in front of me, but basically all drugs have some side effects, but the side effect profile was acceptable. There's nothing that jumps out that suggests that it's a problem. It is given once a week by injection, which is a slightly different way. It's a subcutaneous injection once a week, so that's not too big a deal. And your other point was, I've forgotten, side effects
and whether it had any effect on other symptoms that you experience in PV.
So yes, there is some symptom improvement, and in particular, when we venesect people recurrently, we make them severely iron deficient, and that gives a lot of symptoms, may contribute to things like the itch, tiredness, all sorts of things. So there's certainly some improvements in some of the symptom profile on that drug, because you're effectively giving a drug so that you don't have to make people severely iron deficient.
Great, thank you. I think the only one that's specifically relevant right now was a really interesting and vague sort of general question, more than vague, whether you still think that with all these trials that you've discussed, watch and wait or active monitoring is a valid first action, or whether it would stay that way, which I thought was a really interesting question.
Yeah, so that is an interesting question, but I think we need to take it in context. So these trials are mainly in relapsed refractory myelofibrosis, which would not be a watch and wait group. They're a group where you've already you've made the decision to treat anyway. The only bit that with this group of patients that you may be watching and waiting would be in low risk essential thrombocythemia and some of the polycythemia vera, where you're only controlling them with venesection. So I think it depends on the context. So I've suggested from this that in polycythemia vera, here's a drug that you may be able to use instead of venesection. And that certainly may be a valid strategy. But in essential thrombocythemia and myelofibrosis, I think we're talking about treatments for patients who are beyond the watch and wait stage. So I think watch and wait may be a valid strategy still in groups of patients where at an earlier stage in the disease, but that's not really the groups that we're talking about. And I don't think these drugs you would want to be giving to patients who are only watch and wait. They're for a much more advanced point in the disease. That may be that if they're very successful, and particularly if they reverse the disease process, then you get to the point, should you be actually treating people earlier?
Yep, absolutely. Too early days again, which I'm sure is a really frustrating thing to say, but no, that's good. Thank you for answering that question. Let's move on, because I'm keen to make sure we've got enough time for the other presentation too.
Okay, so the next thing I looked at, because I thought it would be of interest, was what was there in COVID and MPN? And there were a number of abstracts. I've pulled out 4, and I've tried to put in this one slide the summary of what I thought were the main points about COVID and MPN as presented at ASH. So the first one is a European cohort of 479 cases in the second wave. Now, this is very important because this is actually Professor Barbui's Bergamo cohort, or the Italian cohorts, and he actually looked at the first wave and was probably one of the first to publication, and came out with quite alarming figures about the mortality of COVID and MPN in that first wave. So there are a number of points in this second wave that I think are quite important. The first one is that the mortality from MPN, from COVID and with MPN in this second wave was considerably lower than the first wave. So that's very encouraging. The other thing is that they come out with that age greater than 70 and ruxolitinib discontinuation was associated with the need for respiratory support. So somebody who was suddenly stopped their ruxolitinib or who was over 70 was most likely to need ventilation. The other thing, and this is quite important, is that there were, on follow-up, there were no disease evolutions. So in the first cohort, they found a couple of people who got COVID with MPN and then progressed to acute leukemia quite rapidly. And this was a bit alarming. It was only a small number of cases, but it sort of begged the question, did having COVID do something to the disease? But there were no disease evolutions in this follow-up cohort. And that's, again, encouraging. It may just been a quirk in the first cohort that was seen. The rest of them are vaccination studies of various sizes, and I've tried to sort of pick out the points from these. So there was a study of vaccination with the Pfizer and Moderna vaccines, looking at the antibody and T-cell responses in MPN patients compared to controls. On the whole, the responses were very good, but there were some subtle differences with slightly less response in myelofibrosis patients. However, being older, the older the age, actually trumped having an MPN or having a myelofibrosis. So the important bit was that the older people may not quite have as good responses, but they still had good responses. Another study of 63 MPN patients with COVID in a healthcare network, and they found increased thrombosis in MPN patients compared to the general hospital population. That's probably not particularly surprising given the nature of the MPNs. And the last one was a small study, again, looking at the Pfizer RNA COVID-19 vaccination in 30 patients and looking quite closely at the responses to vaccination. And the responses were less on those on ruxolitinib compared to those in other treatments. So ruxolitinib may damp down the response to vaccination to some extent. So that's probably leads back to why the rationale came in for giving a third vaccine in some groups of patients. And that was really all there was on COVID and MPN in ASH 21. I'm just going to finish off with a couple of other points. First of all, the MAGIC study, which was carried out in the UK, looking at people with ET and PV for 5 years on best available therapy versus ruxolitinib. And this study looked in quite a lot of detail at the different groups with the different molecular mutations and their symptom responses, and showed that there were some differences. And perhaps the other poster related to this shows this better. It looked right across at the change from baseline in symptoms on best available therapy, which is the red line, with the blue line below as ruxolitinib. And don't forget, in these graphs, lower you are, the better it is. So you can see right across the whole the 5-year period, the patients on ruxolitinib had better symptom responses than those on best available therapy. And my final slide then, what I've tried to put together, I'm not going to read this out to you, was looking to see what trials are coming and what things we may be looking at. And in ASH, you can actually present a study that is just opening and enrolling. But the idea of this with these 7 or 8 trials is that there's lots of trials which are starting to look at further treatments for MPN patients. So ADORE is an Australian platform where they can look at patients on RUX and keep adding in novel agents. Independence is one looking at a drug, luspatercept, which may help with red cell transfusions. Very keen to see one in ET, but a phase 3 trial is opening, looking at what they call P1101, which is ROPEG is an interferon, long-acting interferon versus anagrelide, and then adding in other drugs in those with suboptimal responses, parasicelib, which is a PI3K kinase inhibitor, imetelstat, which has been around for a while, but a telomerase inhibitor, and another BET inhibitor. as monotherapy, again being used. So a number of new options may come along. Also combining some of these drugs in newly diagnosed patients, ruxolitinib plus the parsalicilib. And finally, an entirely new drug, to me anyway, elotuzumab, which is an anti-SLAM F7. It's an inhibitor of fibrocytes. So this may be a drug, the fibrocytes produce the fibrosis. So if you give an inhibitor of those, would this be useful? So very quick overview on those, but the point I'm making is that there may be lots more things coming, and that's always very interesting. So I will stop there, having gone on too long, but happy to take any further questions.
Thank you. That's really interesting so far. A lot of people saying they found it really helpful, so thank you. Two questions, I guess. Just one on COVID. I think you answered a person's question around the impact of ruxolitinib in your presentation, but someone interestingly asked before the webinar started about whether that would, whether anything you saw at ASH, I suppose, made you more likely to test people for their response to the vaccine, and whether there's any value in doing so. I don't know if I'm open to comments from both of you on that.
We're not testing routinely. I think some people have antibody responses, but certainly our service is concentrated on getting everybody vaccinated. Yeah. I mean, and really I've showed what was there, which was that what we sort of knew, that maybe some people don't make as good a response as others. But don't forget, you're always talking in percentages. I mean, there may be completely normal people out there who don't quite make as much response as others. But it is the rationale behind the extra vaccination. And what I saw suggested that there may be some variations in response, and therefore there's a rationale for that. But there's also a rationale for us all to have a booster, which is the same rationale, you know, is your response still as good?
Yeah, absolutely. I think that helps. Adam, is there any, would you concur with that in terms of whether there's any use of monitoring everybody with MPNs for their antibody response?
There's no proven clinical value of doing that. You know, we are doing that routinely in Oxford because we're collecting data, and I think there are things one can learn from it. But in terms of really informing your clinical practice and helping to inform a particular patient on how they should or should not behave and do things, there's just not good enough evidence to support that.
Yeah, okay, that's really helpful. Thank you. And then one very final question for you, Mary Frances. Someone's asked about, it's quite a challenging question, how long it usually takes for a drug in a trial to become available in the UK. I think they did counter that with they feel like COVID's probably raised their expectations around how fast these things happen. But yeah, any thoughts?
Yeah, I think that actually is the comment about COVID is a good one, because you know, it's amazing how quickly drugs have come up through. Although sad to say, because you have thousands of patients and so forth, it actually has deflected somewhat from other things, in my opinion. How long does it take for a drug to become available and then available in the UK? So the first bit is, I mean, they have to get it through and licensed, and the FDA, the US authorities, are the deciding factor. That is a long process as well, and some of these drugs have been, you know, going through the trials for a long time. There's pharma companies behind that, always very keen to get it through, but then the issue comes when it is available. Of course, we have to get it through the regulatory processes in the UK, and don't start me on being in Northern Ireland. You know, we're not in the EU, or we are in the EU, or who knows. NICE, as far as I'm concerned, is the deciding factor. I actually have a lot of time for NICE. I think they make very good decisions, but obviously it has to go through that. The drug company has to take it to NICE and through that, and that does hold things up a bit. There's always a role for patient advocacy in this process, and that's always quite interesting when you see drugs where there's been a huge demand. The patient advocacy helps that, but I'm not answering the question because I can't answer the question.
I think you're answering as much as any of us could answer it. Yeah, it's we've certainly got extra layers on our system, our healthcare system, that they don't in America, but then obviously they have to pay for that. So yeah, it's hard to say, I'm sure. Great,
and
thank you.
They are overcharged for their drugs greatly as well.
Absolutely. Great, I think that's all the questions so far that I think are appropriate to ask. There's a couple more that I'm conscious not to ask in case Adam answers them. So I'm going to let you come in now, Adam, if that's okay, and keen to hear your perspectives on the conference.
Okay, let's see if I can share my screen first of all. That should hopefully work. And if I... Are you seeing my slides?
I am, yeah.
Excellent. Right. Well, thank you very much for asking me to come and talk, to update on some of the scientific advances at ASH, and also on this quite tough subject to discuss, I think, which is the blast crisis of MPN. So fortunately, it's a rare event, but when patients with myeloproliferative neoplasms do progress to leukemia, it is a very difficult situation to treat. And I'm going to show you some of the updates from some centers who collected their experience of how patients did when they transformed to leukemia. And then just give you a couple of examples of new approaches that I think are worth highlighting. And then we'll move on to some scientific advances. So this was one study that was presented, essentially a single center study where they collected all their information about their patients with myeloproliferative neoplasms who transformed to blast crisis. Just for information, because we'll come back to this, blast crisis is defined as over 20% of these cells called blast cells. They're essentially leukemia cells. So if they go over 20%, either in the blood or in the bone marrow, that is how we define blast crisis or progression to a leukemia. And so they collected 70 patients where this had unfortunately happened in a single center, so it's retrospective study, observational. And then they stratified the patients by the type of care that they received. So about a third of patients who were generally older received supportive care. That means blood transfusions and antibiotics for infection and maybe platelet transfusions, but no active treatment. About 1/3 received these types of drugs, HMA, so these are hypomethylating agents. And in the UK, the main hypomethylating agent we have is azacitidine. And in some cases, and we'll come back to this, azacitidine plus this new drug, a BCL2 inhibitor called venetoclax that we do have access to in the UK. And then about a third of patients received intensive chemotherapy treatment. And you can see in these survival curves, overall, the situation is, as I said at the outset, pretty tough for patients in that these are survival curves. These are how long people are living with time, months on the x-axis here. And you can see, unfortunately, most patients who are diagnosed with blast phase MPN die within the first 12 months of that diagnosis. And there's a possible suggestion of the benefit above just providing supportive care, of adding in these kind of hypomethylating agent treatments, and also adding in more intensive chemotherapy. And also for people who receive chemotherapy and go into remission, those that receive a transplant, some do survive in the longer term. But overall, this is a pretty tough situation, I think, is the take-home message. This was another single center study, quite a similar situation, just collecting their experience of patients with these conditions. And I just highlighted here that they had more patients with this combination of hypomethylating agent plus this new drug, venetoclax. This is a treatment that is available in the UK in hematology centers. And you can see those patients shown in the orange curve are showing responses that are similar to those of patients who are receiving intensive chemotherapy treatment. Which is this 7+3 or flag. So this is potentially an interesting new treatment approach. But still, and it's interesting because it's an outpatient approach rather than these intensive treatments that require patients to be in hospital for prolonged periods. But still, the outcome is overall not good, and we desperately need new approaches to treat patients in this situation. So here's one such new approach. I'm only going to mention it in passing. The drug is called KRT-232, which is an MDM2 inhibitor. And this was a preclinical model where patient samples were transplanted into mice that were then treated with this drug, and that showed some promising effects. And that is actually coming into clinical trials for blast phase MPN as we speak. And then this approach I thought was worth highlighting. So transplant is a curative approach for patients with more advanced myeloproliferative neoplasms. But as you saw, for patients with blast phase, it only works for a minority of patients. So what they did in this study was they asked the question, well, what about the patients who haven't quite got full-blown leukemia yet, but have this increase, a worrying increase in blast cells to a so-called accelerated phase? And then they asked, how do these patients do with a bone marrow transplant, an allogeneic transplant? And the answer is they do just as well as patients that do not have accelerated phase disease. So I think the lesson here is, if there's evidence of those blast cells increasing, trying to go in earlier than you might otherwise do with this kind of more intensive approach with the transplant might be the best way to tackle the situation, rather than waiting until one is dealing with a full-blown leukemia and it's too late. That was everything I was going to say about blast crisis of MPN. If there are, I can't see any questions having come in, so if not, I will just continue.
Not that I'm aware of, thank you.
So in terms of scientific updates, I'm going to tell you a little bit more of a kind of esoteric story about this, in kind of weaving into it some of the abstracts that have been presented at ASH just last year and the year before. And I'm going to highlight two I think, quite exciting studies. I'm an Oxford man, I'm afraid to say. They've both come from the University of Cambridge, but there you are, don't have it all. And they're really relating to how myeloproliferative neoplasms develop, and some really quite remarkable and surprising results. So if we think, I was kind of philosophizing to myself about this, thinking that we understood, or at least I thought I understood quite a lot about myeloproliferative neoplasms and what causes them. And in simple terms, you might think the JAK2 mutation that most of you listening will have heard of, that's what causes the disease, isn't it? I mean, we know JAK2 inhibitors are effective. We know JAK2 is by far the most commonly mutated or damaged gene in MPN. If you put in JAK2 mutations into mouse models, they get a myeloproliferative neoplasm. So it's kind of obvious, isn't it? The disease is caused by the JAK2 mutation. This chap is Michel de Montaigne, who's a philosopher. When I had more time on my hands, I used to read some of the essays he wrote in the 16th century. And one of his kind of catchphrases was, what do I know? Which was kind of really questioning what you think you know, and going back to kind of really think, why do you think you know that? So with regards to JAK2, and does JAK2 cause MPN, I want to talk about this phenomenon called clonal hematopoiesis. So this is a kind of really exciting emerging field where we're learning that as patients age, all of their cells, actually in all the tissues in the body, acquire mutations. And some of the time, those mutations are mutations that are also associated with the disease. And this gets more frequent as people age. So if you look in the blood system, in people over the age of 70, about 1 in 5 people will have mutations that are associated with certain forms of blood cancer, but do not have any other features or signs of blood cancer. And that's shown in this curve here. As people get older, the percentage of people gradually increases that have this so-called clonal hematopoiesis. And that's important because it is associated with an increased risk of the development of blood cancers, such as MPN, but is also associated with vascular disease, heart attacks, blood clots, and heart failure. And if you look at the types of mutations people get, there's certain very common ones in this gene, DNMT3A, that also occurs in myeloproliferative neoplasms. TET2 also occurs in myeloproliferative neoplasms. ASXL1 also occurs in myeloproliferative neoplasms. And here we are, JAK2 occurs in patients with completely normal blood parameters. And in fact, this has been known for a little while, that if you look really hard for the JAK2 mutation in the general population, you'll find the presence of this mutation that, at least I thought I knew, caused myeloproliferative neoplasms. You'll find that in about 3% of the general population. We've got completely normal blood counts. The same applies for the calreticulin mutation. So that's kind of a little bit fascinating. What is it about the fact that many people have got a JAK2 mutation, but absolutely no signs of disease, but some people get a JAK2 mutation and do develop disease? So that leads me on to some quite interesting abstracts that were presented from the University of Cambridge. This one from the group of George Vasiliou, who works at the Sanger Institute, and they looked at this phenomenon of clonal hematopoiesis, but did this fascinating study that will soon be published in a very prominent journal, showing how these clonal hematopoiesis mutations develop over time. So they were lucky to have a very large cohort of patients with serial collection of blood samples, so they could track what happens to the amount of the mutation in people over the course of quite prolonged periods. And by measuring how the mutation grows, they could work out how long the mutation has been developing in patients by kind of plotting it back. And the results are absolutely fascinating in that in many cases, you can predict that the mutations actually arose many years before the patients actually have detectable clonal hematopoiesis. And it varies from mutation to mutation. So for this very common mutation, it's found very frequently in patients with myeloproliferative neoplasms, a DNMT3A mutation. Actually, their prediction was that these mutations occurred in childhood, or actually even in utero before birth, in patients that develop clonal hematopoiesis in their 70s or 80s. These are not mutations that people are born with. They're mutations that arise in a single cell in utero, and then take the whole of the lifetime to actually grow and develop. And this kind of builds on some work, again, from the Sanger group, Jyoti Nangalia, Peter Campbell, Tony Green from Cambridge, who've just published this paper in Nature, where they did something similar, but specifically in myeloproliferative neoplasms. And they took 10 patients with myeloproliferative neoplasms at various ages, grew what are called colonies, so genetic material derived from single cells, and then did some very complicated whole genome sequencing that I won't go into how that works, but it allowed them to trace back the kind of the clonal evolution and the relationship of the driving mutations in JAK2 and when they developed during time. So they can use this approach to calculate that in every single cell in all our bodies, the cells accumulate about 17 mutations every year. In most cases, they're inconsequential. In some cases, it's unlucky and it happens to affect a gene like JAK2 just in the right spot. And then they can use this data to track back to say, well, how long ago did that JAK2 mutation occur? So in this case, in a patient who developed a myeloproliferative neoplasm age 23, they predicted that the mutation arose at some point, either in utero or in the first year of life, and then only presented with a myeloproliferative neoplasm 20 to 30 years later. Same with this case of a patient with polycythemia vera age 32, probably predicted at least to have developed a mutation in utero. I think that's fascinating for many, many reasons, totally unexpected to my mind that it would take so long for a JAK2 mutation to cause disease. But it really does open up all sorts of opportunities where, well, if you could find these mutations a little bit earlier, then maybe you might be able to do something about them before people ever get the disease. And that's this whole idea of early detection and early intervention to try and prevent disease rather than waiting until the disease has reached an extent where there's a birth disease and you have to treat that. And we've just done some work that I thought I would highlight that kind of adds to this overall story. And I'm just going to tell you very briefly about two patients. Patient A, who was a 38-year-old who presented with a big spleen, and to cut a long story short, had myelofibrosis associated with a calreticulin mutation. And the second patient, who aged pretty much the same age, was also diagnosed with primary myelofibrosis associated with a calreticulin mutation. Then if I tell you that both patients were identical twins, and so identical twins who both presented with exactly the same mutation and exactly the same disease, almost at the age of 40. And by doing some complicated genetics that I won't go into, we could work out that almost certainly the explanation for this was that the mutation arose when the twins were in utero, and twins share a circulation, so the cells that cause the myeloproliferative neoplasm many years later were transfused between the twins and then grew in parallel in both twins to cause myelofibrosis 40 years later. So that gives you an idea of the length of time over which these diseases develop. So that's just shown here kind of in a cartoon form, showing that the calreticulin occurred in utero, and then the two twins were born, and over a course of many, many years, they developed myelofibrosis independently. But the fascinating thing here, I think, is not only that there's this very long disease latency between the development of a JAK2 mutation and development of disease, but there are so many patients, as I told you, who get a mutation but never develop disease. Probably about 1,000 to 1, actually, patients that get a JAK2 mutation in a stem cell in the blood system, and 99.9% of them might have that JAK2 mutation, but it never causes any problems at all. And 1 in 1,000 times, it does cause disease. So the question is, what is it about those patients that makes that JAK2 mutation cause the disease compared to in other patients where that does not occur? And I like to think of this in two different ways. You'll never see a slide with Darth Vader and Harold McMullin on the same slide. I will guarantee that. This is Darth Vader here talking about destiny to Luke Skywalker. And the idea here is that it might be the destiny of the original cell that acquires the mutation, either because of the other genetics that people are born with, or the type of cell that gains the mutation. And it just sets the path for that mutation to cause the disease or not. And here's Harold McMullin talking about events, dear boy events. And the question is, are there other events that cause a cell carrying a JAK mutation in some patients to cause disease? And that could be all sorts of things. Environmental exposures, it could just happen naturally as people get older. It could be something relating to the immune system. It could be something relating to inflammation. I just wanted to highlight a really important study that Mary Francis is leading called the Mosaic study, where she and others are trying to learn about this. What are the environmental exposures that people are exposed to in more often than case controlled patients? that might help explain this phenomenon where some people are developing a JAK2 mutation and disease, and other people are not developing the disease. And I'm just going to leave you to one of the abstracts that were presented at ASH was presented by one of my postdoctoral research fellows. And to take us back to the blast crisis, what we did was we studied using a very complicated single-cell genomic technique that I won't go into. We studied this particular mutation in P53 and how that causes leukemia transformation in patient samples from patients with myeloproliferative neoplasms who develop blast crisis. And I'm just going to show you one slide that summarizes the key findings of that work. What we thought was the absolute crucial thing here was the role of inflammation. So patients that acquire a P53 mutation in the presence of some kind of inflammatory insult that might be caused by a whole range of different things, as yet we don't know. It confers a very strong advantage to the cells that have this mutation. And the cells that don't have the P53 mutation are actually suppressed. So it's like if you think of a kind of, if it's like a competition or a race between the different types of cells, some that cause the leukemia and some that don't. It's a combination of the leukemia cells kind of running faster, if you like, in the presence of inflammation, but also the non-mutant cells actually being suppressed and stopping. And it's that combination that seems to be absolutely crucial. But the question is now, I think, what are the inflammatory insults that might cause this? And is there anything we can do to intervene a little bit earlier to try and prevent those subsequent, very difficult to treat blast crisis transformations? And I think, you know, I think that is the way the field is going, thinking more and more and more about how we might intervene earlier in the disease course to prevent that disease progression rather than trying to deal with it when it happens. So thank you very much for listening. I hope some of that you could follow. And questions?
Thank you, Adam. That was really, really interesting. I think you answered this question, but is there anything we can currently do to help prevent progression to AML?
I think one of the things that can be done in patients where we're really concerned about the risk of development of leukemia, and that particularly speaks back to this study that I mentioned about accelerated phase patients, where those blast cells we don't like to see are beginning to increase to a worrying extent. Getting in at that stage and treating and trying to reverse this disease trajectory towards leukemia seems to be the crucial thing to do, rather than, you know, and in many cases you can pick up the disease during that trajectory rather than a sudden event where patients suddenly develop blast crisis. So I think, you know, thinking if someone is eligible for allogeneic transplant, I think that, you know, that intervening a bit earlier in the disease course is crucial. If someone is not eligible for allogeneic transplant, there are still treatments that look promising in these accelerated phase patients. So we ran the phase R study in patients with myeloproliferative neoplasms, which combined the JAK2 inhibitor with this other treatment that I mentioned, hypomethylating agent, or azacitidine. So it was ruxolitinib plus azacitidine. And again, in that study, patients with accelerated phase disease did better than patients with full-blown blast crisis. So the general message, I think, is if there are worrying signs with the disease and one is worried that the disease is progressing towards leukemia, that's the time to try and do something about it.
Great. And again, this is one of my questions, and maybe I'm taking what you've talked about a little bit too far, but do you see a world where you could predict or prevent an MPN from developing in the first place, or would the scale of the testing that would need to be done be prohibitive in that setting?
Well, you know, I'm to a certain extent an optimist, and you know, I think if you would have asked me 10 years ago, did I think we'd be living in a world where we're routinely doing very cutting edge next generation sequencing approaches on patients with myeloproliferative neoplasms and looking at those results and using them to make management decisions, I would have said that's science fiction. And yet here we are, we're doing it. Whole genome sequencing is definitely coming into routine practice. So I think that's exactly the way we should be thinking about this. You know, I think more and more the genomics is coming through. It's getting cheaper and cheaper and cheaper. And I think in 10 years' time, that is exactly the kind of thing we'll be contemplating. The challenge is to gather the evidence that, you know, that you can really do something that makes a difference. And as Mary Frances nicely outlined before, that is a particular challenge in myeloproliferative neoplasms that develop over such long periods, because you have to do a monumentally large and long study to get the answers that you need. And the fact is no one is ever going to fund that study. So you have to try and answer the questions in roundabout ways.
Absolutely. And a question I suppose that may be more relevant to those listening is people already affected by MPNs. Does your work showing that, showing that JAK inhibitors, JAK mutations, I should say, are more present in people without MPNs. Does that explain a little bit why JAK inhibitors don't work universally or stop working?
I think that's a really smart point. I think it does speak to that point exactly. But well, if the JAK2 was the simple cause of the disease, simple in inverted commas, then surely by inhibiting JAK2 you would reverse the disease. And we all know, unfortunately, in many cases, or in most cases even, the JAK2 inhibitors help, but they certainly don't reverse the disease, in most people, that is. And I think it speaks exactly to that point, that there are certain things that we don't understand, and we have to be humble about that, and we have to do the research studies to try to understand them, so that we might think, you know, how might we combine a JAK2 inhibitor treatment with something else that tackles maybe the inflammation, or maybe the epigenetics, as Mary Frances was outlining, or maybe something else. But we need to do the research to understand that.
Yeah, absolutely. Mary Frances, Adam touched on a study you're doing, so I'm going to direct this to you since you happen to be here as well. Somebody asked about passive smoking. Is that something that you're exploring in the study that Adam mentioned, rather than just active smoking, I guess?
Okay, so the Mosaic study does extensive occupational environmental studies in people with fairly recently diagnosed MPN, because that gives a cleaner sample. And certainly passive smoking would come into that if somebody was as an occupation, well, it doesn't work anymore, but you know, in the past, barmen or people like that. So that would cover that. But all that study will show is what could be associated. And we've already found some associations from the original pilot study. But the idea of that is to do a much, much larger study and see what associations come out, which then gives a basis for further research. Smoking is associated with the development of MPNs, but at a much lower level than, say, it is with the development of lung cancer. And I'm sure passive smoking, to an extent, in the same way, I mean, it's a carcinogen, so it's almost bound to come out as an association in the same way as it does with lung cancer, because it's a lot of exposure to that agent.
And I think you make an important point about the difference between association and causative agent. I think proving the cause of a cancer is a much more difficult task. Absolutely. I think that's all the questions specifically on what you guys presented. There are some more general questions, if I may pose those to you. Somebody's asked if there was any information on treatments that would help their white blood cell count to recover specifically. They're currently on hydroxycarbamide with some venesections. Is that something you're aware of at all, either of you?
So hydroxycarbamide suppresses all the blood counts. And obviously you have to monitor that on patients on hydroxycarbamide. If somebody is refractory 2-hydroxycarbamide, there's criteria for that, which may be that it's pushing the white cell count too low, and then you have to back off the treatment a bit, and then you don't achieve what you want with reduction of the hematocrit. So the second line treatment for polycythemia vera now, ruxolitinib is licensed now for relapse for polycythemia vera, which is refractory to hydroxycarbamide. So there are options like that now in somebody who it was bringing the white cell count too low, and therefore they weren't able to take that. Another drug that I've been involved in for some time, but it's still very much in the trial stage, is Givinostat, which again, is the patients going into that are ones who are getting their count too low on hydroxycarbamide.
Great. Hopefully that person finds that reassuring. Thank you. Somebody's also asked about an antibody therapy that they heard about previously against ET to reduce megakaryocyte production. Is that familiar to you, Mary Frances, and do you have an update at all on that? That's quite a difficult question.
This is the work that the Danes have been doing with the CALR antibodies. Now, that was the big news the year before. The last presentation, and Adam may correct me if I'm wrong, but the last presentation that I saw on this, I think in November, it didn't produce the responses to the CALR antibody that hoped, although they were getting quite a long way along with developing the technology. And certainly there wasn't anything in ASH this year about it, or if there was, I missed it. So I think it's still being worked on by those groups, but they don't seem to have produced anything more this year. Adam, I don't know whether I've missed anything.
Oh, I think that's the current status, but you know, I suspect if them trying to move from a phase where they've got an antibody to actually getting something that's gone through all the preclinical safety work to get it into a trial does take a year or two. So I suspect we'll be seeing things happening in the next year or so.
Great, thank you.
I think it's a very, very exciting approach actually, and the mutant CALR is a very tractable target for so-called immunotherapy. So I think that will be very exciting to see how that develops in a few years.
Clearly got some very informed patients in the audience today. They're talking about things that I struggle to keep up with. The very last question, I think, so I guess a bit of a warning to everybody in the audience that if you have a burning question, now's the time to ask. But the last one I've currently got is around how food might inhibit JAK2 inhibition. They'd seen a study from 2014 that suggests that some food may inhibit JAK2 inhibitors, which is a really complicated way of saying it. Are either of you familiar with any work in that area at all?
I'm not quite sure what they're referring to there. So there are certainly some interactions between foodstuffs and the metabolism of JAK2 inhibitors. So Seville is grapefruit, and there's certain things that you have to be quite careful with, that they alter the enzymes that metabolize ruxolitinib. But in terms of foods that directly inhibit JAK2, no. I don't think certainly there's no research that I'm aware of taking that forward as a potential approach, in terms of dietary measures that might be tractable in MPN. I don't think that's happening.
Okay, no worries. Well, if you need any more help with that particular question, I can't remember who asked it, please do get in touch with us and we'll try to help you understand a little bit more about that. The last question is a very specific question about whether you would treat someone with particular features, which I think is a little inappropriate, unfortunately, for this forum. I think that I would recommend that person, please do go speak to your haematologist if you're not sure what the best treatment option is for you. Yeah, this isn't really a forum in which we can talk about treatment options for specific people, unfortunately. Great. Okay, well, thank you both for some really fascinating conversations.
Sorry, I thought there was a question about Prakritinib as an alternative.
Oh, I missed that one. You're right. Yes, thank you, Adam.
Yeah, just because I think there is some exciting news there in that the Cancer Drug Fund has approved the use of Prakritinib in patients who have had an inadequate response to ruxolitinib treatment. So that has become available, and people are starting to use it. So there's the answer to that question. Prakritinib is now available. It's for certain groups of patients. So myelofibrosis, intermediate to or high risk, and with an inadequate response to ruxolitinib, typically defined by a big spleen that hasn't really responded properly to the ruxolitinib treatment.
Great, thank you. No, that's a really important one that definitely did not want to
really
miss.
Exciting to have a new licensed drug in myelofibrosis patients is a huge step forward. I've used that particular treatment in a few people now, and it's an exciting step forward for us all.
Great, and hopefully some of the other ones that Mary Frances presented will come along equally. You always do hope for more in the future.
Yeah.
Perfect. Thank you both so much. I think we've exhausted the questions, but everybody's saying they found it a really interesting, informative talk. So we really appreciate your time in filtering through all the information that I know comes out of the ASH conferences. I find it challenging myself to do so. So yeah, thank you again for taking that time for us and for the patients that are listening, and family and friends. I'm just going to end. For those of you who may not be 100% familiar with other things we do, I hope this few end slides is really helpful. So we're currently in the process of planning our webinars for the rest of the year, and in the feedback form you will see a little box that asks what more you'd want to see in terms of webinars. So really would appreciate your feedback on that. I hope you found this webinar really useful as well. We've got lots of other ways of sort of keeping in touch with information on MPNs and leukemia, which you can find in lots of different formats online and in hard copy. Our next magazine is due to land on doorsteps very soon. Next slide, please. Don't forget, we've got our booklets. If you're fairly new to MPNs, been recently diagnosed, our booklets are probably the best place to start for a bit more of a beginner's guide. So please do have a look at those. Next slide, please. Got a range of support services, whether you're looking for peer-to-peer support or whether you're looking for more professional help in terms of counselling and things like that. We can help you with all of that. So please get in touch for whatever you need. Next slide, please. Just to say that we are currently piloting a few support group meetings specifically for patients affected by ET and PV at the moment. So if you're keen to meet with others with the same diagnosis as you, would really recommend you come along and have a chat to others affected. These are going to be held online due to the sort of number of people we can get in a room at present. So find out more on our website, and it's in a very it's on Zoom, so a similar format to this. Next slide, please. If you want to sort of discuss in a bit more detail how the latest scientific updates apply to you specifically, if you're interested in clinical trials, for example, you're trying to make a decision between treatments or anything like that, our advocacy caseworker is a really good person to discuss that with. They're there to talk to you for as long as you need to help you make the decisions that you're being asked to make. So please do get in touch with us. Next slide, please. A couple of fundraising bits and bobs. If you're keen to help us carry on making these webinars, we'd really love your support. If you are not really into exercise, or you're looking to set your own goal, you think a marathon may be a bit too much, Step Out for Spot Leukemia is a really nice way to help out, because you can set your own goal and just sort of set yourself a challenge that's perfect for you. Next slide, please. Or if you are feeling brave, we're looking for more people for our team for the London Landmarks Half Marathon, which I must admit is only for people who are very brave, not one for me, but please do get in touch if running is your thing. Next slide, please. A range of ways you can keep in touch with us if you're into social media. Next slide, please. And I'll leave the support lines and email address up while I just thank our speakers. Thank you again, Mary Frances and Adam, for a really interesting talk today. It's been, yeah, really interesting discussion. Looking forward to seeing how it progresses over the years. And have a lovely evening, everybody. Thank you.
Thank you. Bye-bye.
Bye.